This is a production of WKNO Memphis. Production funding for Behind the Headlines is made possible in part by the WKNO Production Fund, the WKNO Endowment Fund, and by viewers like you. Thank you.
Local health officials on Ebola preparedness tonight on Behind the Headlines. I'm Eric Barnes, publisher of the Memphis Daily News. Thanks for joining us. I'm joined tonight by Dr. Helen Morrow, Health Officer with the Shelby County Health Department. Thank you for being here. And Dr. Manoj Jain, Infectious Disease Physician for Baptist Memorial Healthcare. Thanks for being here.
Pleasure to be here.
And Bill Dries, Senior Reporter with the Memphis Daily News. We're going to talk about preparedness for Ebola. We joked a little before the show how to even introduce it. I was going to say, get ready for Ebola, and that seemed to be hyping it. I think we want to, as much as anything, kind of talk about the realities of the healthcare community and what you all are doing and what the local folks are doing. But as we said, we're also going to talk about the flu and talk about some other things that are probably more immediate, issues for people's health. But let's just start with you. What are hospitals, what is the healthcare community in Memphis doing, and what should it be doing in case of a worst case scenario?
Sure. So one thing we have to keep in mind is the general public does not need to panic about Ebola. The group that has to be concerned is the healthcare community, because we have seen that it can spread very quickly within a hospital setting, within a healthcare community, as we've seen in Africa. And so what we are doing at the hospitals is training our staff. We're training the ED doctors, the emergency room doctors, the emergency room nurses, and other key staff members who would be responsible for identifying a case, for managing that case initially until we get further guidance from the health department and from CDC. And so all those trainings are happening now, and in many cases have already happened with our key staff.
I mean, is that part of what was learned from Texas, is that, they made some mistakes,
sure.
and it was healthcare workers who ended up getting exposed, and obviously it was tragic that the man from West Africa died. Do you look at that and just try to learn from that?
Absolutely. We learned a great deal from what happened in Dallas, and over the process, CDC has also changed their guidelines, and that has allowed all of us to be much more vigilant on how to manage a patient, how to identify a patient, and then subsequently how to work as a team.
Okay, more questions. Bring in Dr. Moore. From your perspective, the county health department, what's your message to people as they hear about Ebola? They see sometimes some really hyped stories about Ebola, feel like it's imminent. What's your message?
I will go back actually about 11 or 12 years ago in emergency preparedness after 9/11. We were worried about anthrax here. We were worried about smallpox being used as a bioterroristic agent. So we have been actively working on preparedness in this community for over 10 years. The health department is very involved in this, and we're following state and CDC guidelines. We're trying to push out messages to aid the local health community as far as how to screen someone, what to do with them, guidelines for preparedness, for equipment to use, to treat, isolate, and so on and so forth like this. We have also worked with various parts or other entities in our community, the law enforcement, the fire, the EMS system, to educate them and instruct them on how they can be involved in this and how to prepare for it.
And is it sort of a gross simplification that for me to say that in part of what went wrong in Texas, and I'm not picking on them, it's just a learning experience, is that misdiagnosed, they missed the opportunity to diagnose him and identify and screen him properly at first. And so is that why you go to, say, EMS? I mean, just everyone needs to be on the front line of if this really, you got to screen for this and catch it early? I mean, is that the message?
We want to identify someone early and get them into observation and treatment as early as possible. We were preparing, but I don't know that we were really thinking that we would have an actual case as immediate as we did.
Yeah.
So we were still in the preparation phases, and the signs and symptoms of Ebola overlap or mimic many other diseases, so it's hard to diagnose. And if you're not thinking about it, you don't necessarily include it in your differential diagnosis when someone presents.
Yeah, okay. Bill.
Also, during the discussion that we've had about this, even before Dallas came into the headlines, as you mentioned, we were already dealing with the flu season. From your perspective, it seems as if this is not just about Ebola. This is about preparation in general.
Yes, it is. Yes, it is. And this is a new thing that we have to worry about. We have worried about other things in the past. And like I said, I go back to when we were worried about smallpox being used by a terroristic agent, how we would screen people that presented for that, or what we would do with people that had been exposed to it and were not sick, and how would we observe them, quarantine them so it's not spread in the community also.
Dr. Jane, to those of us who don't work in public health, I think we kind of looked at what happened in Dallas and said, okay, there was a mistake made here.
Sure.
For health officials, for scientists, this is a normal part of the process of the practice of medicine, or the practice of public health, is it not?
Sure. So 2 opportunities for us to learn from the Dallas experience. I think one is the medical error that happened when the patient initially came in, Mr. Duncan came in, and the diagnosis was missed, or at least a question was not asked, or a question was asked, but it was not acted upon. And so this is a whole area of medical errors. We know from various studies, the Institute of Medicine has done a great deal of work on medical errors. And what they found is as many as 100,000 deaths may occur from medical errors. What we can use this opportunity from the Ebola experience is, how can we better classify medical errors? How can we better have our healthcare providers work better in a situation when there is a potential error? The other area that we learned is all about isolation. That isolation, we have those capacities in the hospital, but Ebola is a very different category of disease than MRSA, the staph infection that we have, or other resistant bacteria that we need to deal with, such as C. difficile. And all of those conversations have really started in the hospital in a big way.
If there were a patient, and we should say there were a headline, a week ago,
Right.
Someone was brought to Methodist University, maybe was showing signs, and that was ruled out. I think you said
Exactly.
that night.
Yes.
But right now, are the guidelines, I don't know, I'll ask you both, if there were a patient, they were identified as having Ebola, would they be treated locally, or would they be as quickly as possible taken to the CDC, Emory University, or to one of the, or NIH, and
Right
one of the other
now-
places that's treated them?
Right now, they're talking about tiering the hospitals, tiers 1 through 3.
Okay.
And there are 4 such biocontainment units in the United States, and most places are going to fall into the secondary tier.
Okay.
And from the last conversation that I was on, they were talking about trying to get them probably to one of these 4 biocontainment units, but the bed capacity is very, very limited in
Okay.
these. It's
Yeah.
I can give you an idea what we're doing in Memphis
Sure.
at various hospitals. At Baptist Hospital, they have all facilities need to be prepared for a patient coming into the ED, all the way from Oxford to Arkansas. So all have facilities at the emergency room level. However, if a patient has to be further cared for and there's a potential case, they would be either shipped to Baptist DeSoto, Memphis, or to NEA
Okay.
in Arkansas. At Methodist, that's what happened in this case. They came to Methodist South Hospital, the patient, and then they were transferred over to Methodist Central. And so Methodist Central is sort of the central location where patients would be then further evaluated and treated after that initial visit to an emergency room somewhere else.
And when we talk about this, statistically, we're still, I just want to be careful and say,
Right.
statistically, this is a very small.
Very low probability
Right.
of someone having Ebola. However, patients who are traveling from Africa often have other illnesses such as malaria, such as salmonella infection. And so we have to be very cautious because the presenting symptoms are nearly identical.
Yeah.
You cannot, as an infectious disease doctor, I cannot tell a patient who has Ebola, who has malaria, or who has typhoid fever at the initial
Right.
presentation unless I get the laboratory test.
Yeah. And where are each of you in terms of this whole debate internationally and up in Maine and New York, New Jersey about quarantining? I'll go with you first. I mean,
Sure.
if right now they're routing everybody through certain airports, so I mean,
Right.
there is no direct flight from West Africa to Memphis, obviously. But if someone came in, do you think that those folks should be quarantined wherever they are? Is that a 21-day quarantine appropriate?
Yeah. So I go with what the CDC has to say.
Okay.
I'm very confident in the recommendation of CDC. A lot of my colleagues are as well. I think that's a very appropriate way of doing it. I would go with the CDC.
And which are?
I mean, Dr. Morrow can tell more of the details,
Sure.
but it doesn't require this quarantine for 21 days. So
Yeah. What are the
there-
CDC guidelines?
Well, there's a difference between isolation and quarantine. We use them somewhat as the same, but they're actually not. Isolation, you remove yourself from an area, from public
Right. But you might do it at home.
activity.
You might just
You can be isolated
I
in
gotcha.
different places. You may or may not be ill.
Okay.
Quarantine is when you are isolated because you have been exposed and you may develop
Okay.
the illness.
Okay. Okay.
And this is what we worried about many years ago with smallpox. If someone had been exposed, they would be quarantined and observed for a period of time to see if they developed the symptoms or not.
Okay.
And the CDC does have guidelines, and people are assessed as far as their risk factors, what their activities were, the time frame, and so on and so forth. And it goes down through several tiers right now as far as the risk you have of developing active disease.
I got you. I got you. Bill.
How much did we learn in 2009 from H1N1 here? What kind of a learning experience was that in terms of setting the stage for this?
Well, it was still part of preparedness and trying to respond to a disease that had arisen within our country. Now, we do know that we see flu every year, and that particular strain was new to us and was a bit more lethal than what we had seen in the past, and especially with children. So we were trying, the CDC and the various entities were trying to develop a vaccine to give to the populace in a reasonable amount of time. And we did that as quickly as possible and tried, and that's part of public health's duty, is to try to provide preventive measures or treatment measures to the community within a certain time period if something like this does happen.
Mm-hmm.
I think in ways, actually, the learning experience for me also was what the media was able to do and can do. Just having the media being able to take H1N1 to a new level of public consciousness was incredibly important. And I think that, in my mind, changed the way we in public health need to be thinking about diseases. We've got to be thinking about what the end message is going to be, and then to tailor the conversation in the way that we have a very appropriate public response with the media partnering. And I think the CDC has done a very good job, and as well as the local health officials on this.
Yeah, go ahead.
You've also both talked in the press conferences that we've had here about identifying someone's travel history, getting a good history on where a person has been, and that's actually one of the first things that I think you've done is, have you been to West Africa? And then from there it's, okay, who have you been in contact with all along the way? So this is not all medical, I think, in the sense that we think about, okay, what are your conditions? That's a very important part of this.
The first three questions are, where have you traveled? Or have you traveled? Have you traveled outside of the country? Mm-hmm. Where have you traveled outside of the country? And when have you traveled outside of the country? And then we start drilling down to activities during their travel to continue to assess their risk.
When you talk assessing risk and exposure and so on, some of that we talked about healthcare workers and the case right now that's making a lot of national news of the nurse who was with Doctors Without Borders, goes through New York. And how do you, as healthcare professionals, when you look at that, I mean, does it worry you that her experience will cause other healthcare workers to not go help in West Africa?
Yeah, absolutely. I think her experience in the media is detracting from the real focus that should be, which is to care for patients in Africa and for us to prepare for a potential patient. Right? There is no reason for us to be spending so much time and effort on one doctor who's come back.
Right.
And then I think it's going to have other doctors. I'm actually very surprised there's so many people who are willing to volunteer. Thousands. And if they're out there selflessly working, we need to support them.
Your thoughts on that too? I mean, does this kind of bad experience, the quarantining and so on, dissuade some healthcare workers from going over to West Africa?
It may very well dissuade people, but they are volunteering to go into what was termed at one time a hot zone and realize things that may be required once they return. Part of this is in response to a great deal of public concern and misunderstanding about this disease. And sometimes you will overreact to public concern. And this seems to be a bit of that. Scientifically, she does not necessarily, according to the guidelines, have to remain in one place, but there's such a great concern from the public that sometimes it's better if you behave in certain ways to help assuage concern and fears. Yes.
Okay. Let me take a minute and talk about this concept of the guidelines and maybe a life cycle of a guideline or recommendation. Right. So you have a problem such as Ebola or the flu, and in that problem, if you have some research, some basic science research. You add in a group of experts, and then they get together and they develop a guideline. So now you have a CDC guideline or WHO guideline. Now to that guideline you add politicians. And then you get law or a regulation, such as quarantine and so forth. Now, to that law or regulation, you add the media and sort of public concern, and then what you get is this either abundance of caution, and when we go overboard at times, or lack of caution, such as with the flu. And so we have to watch this entire cycle of messaging that happens. And each element, the politicians, the media, the experts, and to be very tempered in a conversation.
Well, and it's interesting too, I don't know how to frame it as a question, but what you talked is this very complicated process with a lot of science and a lot of public health issues. Politicians don't like complication, and the media doesn't like complication. They want, the gist is they want a simple answer, the 5-point plan on day one when Ebola hits the news, and to stick to it. But you are talking about a much more complicated evolutionary, we get input, we adjust. That doesn't work in the media.
And it's very rare that the guidelines change at the pace they've changed for Ebola. We're talking about days and weeks. This doesn't happen in healthcare.
But does that feed this? So what happens in the media generally is that, or too often is, they don't know what they're doing. They keep changing their direction. They keep putting out new policies. They're at sea. Is that your experience with the CDC? Is that they don't know what they're doing and they're reeling and they're making things up? I don't think that's what you're saying.
No, but CDC's acting and reacting to the science, to what's happening on the ground. And I think it's very appropriate, that's what you have to do. But when the media or the politicians criticize the CDC or other agencies for hospitals saying, look, you haven't done your job. Well, it's really hard to predict how a virus is going to interact in a completely new environment. We try to guess as best we can. But we cannot be perfect in those ways.
All right, Bill.
We've also talked here about the same symptoms with influenza, and we're in the midst of that season, and that is something that you're certainly not overlooking as well here.
No, we try to promote and educate people about influenza every year and urge people, it is a preventable illness. We do have a vaccine available for it. So we try to like I said, educate the community and urge that they take advantage of the vaccine.
Are more people coming in because of their concerns about Ebola for the flu vaccine?
I don't have any numbers because we have so many places now that give out the flu vaccine, so I don't know what the uptake has been so far. I have had personal experience with some people that have actually, with all of the concern over Ebola and the overlap with the symptoms with the flu, have actually said, I got a flu shot for the first time this year.
Let me
Go
talk
ahead.
a little bit from the healthcare perspective, healthcare workers' perspective. What we've seen is the hospitals now have made it mandatory for healthcare workers to get a vaccine, the flu vaccine that is, or wear a mask. And that has profoundly changed.
That's only in recent years.
That's
that
just
changed.
as recent years.
Yeah.
And so, from the healthcare workers' perspective, now it's a must, and I think it's the right thing to do. That's where legislation and policies can make a huge difference.
Just to switch gears back to Ebola for a time, you were at a town hall meeting with Senator Alexander,
was.
and you talked about some biocontainment centers. I believe you had mapped out a system of these beyond the 4 that I think you had talked about that we have here. What have your thoughts been since then? Because Senator Alexander was interested in that, did some quick back of the envelope calculations.
Sure. So one of the things that we have to realize is to contain Ebola and to manage Ebola in America. It's a low probability disease, and it is not worthwhile for us to train an entire hospital staff on management on every single hospital in North America. That is just a waste of our time, effort, and resources. Yes, we need to train the ED staff, but then for the management, we need to designate a facility in each major metro centers. And if we do that in Memphis, if the hospitals gather together, there's a chance that we could have one facility. In other places, New York City did that. And Bellevue Hospital is one area that they decided that that's what they were going to put all of their, anyone who is suspect case. And so I think we're moving towards that as we evolve with the Ebola preparedness in North America.
But because logistically, if someone with Ebola showed up in an emergency room, and you're talking about a 21-day cycle here to see, and healthcare workers who come into contact at that hospital, that's a real crisis for a hospital.
It's a huge crisis. Absolutely. Management of a patient in there, and then those patients who may have a heart attack or a leg fracture or something, they will not go to a healthcare facility that may have house a particular patient because they may feel that, oh, we don't know what's going to happen. But
And it requires a certain level of training of the personnel. So you have to have a specific cadre of personnel that are trained specifically for this. And it also requires a change in the physical layout of an institution to perform the duties and protect the healthcare workers and the patient most appropriately.
Right, and it's a smaller population. If you're watching those healthcare workers at such a center, you're not watching a larger group of doctors and nurses who are at all of the hospitals that we have.
It would be a set number of people or a limited number of people that would be doing this.
I mean, almost think of this as a model for the hazardous material management model, right? These are individuals who are highly trained. They know how to take on or put on and take off that suit, which is incredibly difficult. We were in training yesterday, and I'll tell you, it takes about 10 to 15 minutes to take it off properly. There are a set of 10 instructions you can simplify out of 40 sets of instructions that are there, and you've got to be very meticulous.
You said, we just have a couple minutes left in the show. You said something going back to H1N1 in the media, that the media did a good job, I think you said, or in part, with H1N1. Was that, expand on that, because I'm curious, because we've been beating up the media, and the media's coverage of Ebola has been not so great in terms of its hype and so on. But you said there was
Sure,
something good.
I don't want to make a judgment on a good or bad job, but I think what we saw was the power of the media in in its influence with an infectious disease and its management and which way it can go. And many people in public health and healthcare, we knew that in the back of our mind, but it sort of brought things to the surface. And in the case of Ebola, I think that's helped us to the H1N1 in preparing and in talking to the media, and I think that's what's been good, at least from my perspective, in seeing an infectious disease and its evolution, right? It changes week by week. I'll tell you, when the first nurse got infected in Dallas, and I was mortified. I felt terrible. When the second nurse, I said, "Wow, what's going on?" And so these evolutions happen in an infectious disease, and so how does the public health system, how does a doctor talking to a patient tailor the message?
I got it. But the message, and we just 30 seconds left, probably the most important thing you would say is get a flu shot. All this talk about, is that correct?
Get a flu
Both of you would
shot.
say, yeah, that really is the
Right.
fundamental thing that people should be doing.
And the general public
don't
need
worry.
not panic. About Ebola, we need to help the people in Africa, and the healthcare workers do need to be concerned and prepared.
Okay.
The public, there are other diseases that are vaccine preventable, that are adult diseases.
Yeah.
May need a flu vaccine, may need a Zostavax vaccine.
Okay.
May need some others.
Right. All right. Well, those are the most important things. But thank you for being here. Thank you, Bill. Thank you for joining us. Join us again next week. Good night.